The authors have no financial interest.
We have many patients having 20/20 vision but still unhappy. In this video, we have highlighted the different problems that can be associated with the 20/20 vision and patient being unhappy. As you all know, sun is setting on the old mindset of cataract surgery. It's a golden triangle which is very important: premium surgeon, premium IOLs, premium surgery as well. We have to consistently hit the bullseye, especially in a multifocal and toric lens and EDOF lenses. We also have the changing profile of the cataract patient, which is a very huge problem right in front of us. The old traditional multifocal lenses used to give good vision for distance and reading 30-35 centimeters. But the intermediate vision was a problem. And that is the reason for the new generation IOLs, which gives a continuous range of vision, starting from 35 centimeters to 50 centimeters to 80 centimeters to 3 feet and infinity. In other words, the near point has receded from 35 centimeters to 60 centimeters, and the new intermediate vision, the new middle as I call it. Case 1 is the refractive multifocal, 6, 5 and 6, patient not happy because of glare halos. The photic phenomenon, halos, starbursts and significant glare can be very troublesome to the patient. I had to exchange this lens for a monofocal lens for this patient. Case 2 is an EDOF lens, 6/9 and 6, patient not happy. There is a crack right in the visual axis, and this was causing polyopia, light scatter, and significant drop in the contrast vision. Obviously, we had to explant this lens as well. Case 3 is a patient with a multifocal restore lens complaining of misty vision. The OCT is normal, there is no PCO. It's because of the glistenings, which can cause a significant drop in the vision. Significant drop in the night vision, as also significant drop in the quality of vision as well. Case 4 is a multifocal IOL, 6/6 and 6. Patient complains of a decrease in the contrast. Slit lamp shows very thin PCO and PC wrinkles. You can see this picture, there is no PCO as such, only PC wrinkles are lying on the PC. Obviously, when he did the YAG laser capsulotomy, the patient became very happy. Case 5 is a monofocal lens, patient not very happy. But if you see the fundus, everything is normal. But if you do the OCT, patient has a cystoid macular edema. This patient was put on topical steroids and Nepafenac, and the patient became completely alright and very happy as well. Case 6 is a multifocal Technis lens, 6/12 and 8. Problem was residual astigmatism. Even low degrees of astigmatism in multifocal lens needs to be corrected with the toric lens. Obviously, in this patient, the toric lens was not put, and because of that, the residual astigmatism, and the patient became very unhappy as well. Case 7 is a Technis multifocal lens, 24 diopter in the right eye and 24.5 in the left eye. Patient had a post-operative surprise of 2.5 diopter in the right eye and +2 spherical in the left eye. The reason was dense asteroidalosis in both eyes. When you have dense asteroidalosis, you can alter the refractive index, and because of that, you can get a wrong power. The power was calculated on IOL Master Lens Star Immersion A scan, and this patient we had to do an IOL exchange as well. Again, another patient with the crystal lens complaining of a sudden drop in the vision. The crystal lens can move forward and produce what is called a Z syndrome, wherein the forward movement and torquing of the lens, and there can be a myopic shift. This patient also required an IOL exchange. Case number 9, multifocal lens, patient not happy, ocular surface issues. The ocular surface like blepharitis, MGD and dry eye can be a major problem, cause for unhappiness in patients who got multifocal lenses, especially, or any type of lenses for that matter. In this patient, the ocular surface, you can see that severe dry eye, and once we treated the ocular surface with lubricants and also ointment, lid hygiene, and also IPL, the patient became very happy. Again, another patient with a symphony lens in both eyes, and the patient was very happy with the vision but not happy with the negative dysphotopsia. As you know, this negative dysphotopsia can be a really troublesome problem to the patient, and it occurs only after a perfectly done surgery. The negative dysphotopsia in this patient was very troublesome, and I asked the patient to wait for 3 months and 6 months After 6 months, the negative dysphotopsia, fortunately for me as well as for the patient, disappeared. Case 11, restore lens both eyes, postoperative refraction 1.5 cylinder in the right eye, 1.25 cylinder in the left eye. This is because the posterior corneal astigmatism was not taken into account. This was prior to the advent of the IOL Master 700, where the PCA is very, very important nowadays, especially when you're putting a toric lens. Again, a patient with the PSC, cataract dense PSC, synergy 66N6, but patient not happy. Reason is we failed to do an OCT preoperatively because we thought the fundus was normal. But if you look at the OCT, you can see there is a vitreomacular traction. And because of that, there was a metamorphopsia for this patient. Patient was, though he had 66N6 vision, was very unhappy. So preoperative OCT is a must for these patients, for all the patients especially. Again, a patient with the post-LASIK trifocal failed to do a topography preoperatively. You can see that decentered ablation. Decentered ablation, on top of that you put a trifocal lens, it's adding fuel to the flame. Again, another patient with a trifocal lens, patient again not very happy. The reason was the angle alpha. The angle alpha is the difference between the optical axis and the visual axis. In this case, the angle alpha was more than 5 and not suitable for a multifocal or trifocal lens. Case number 15, refractive multifocal lens done in 2002. Both eyes, the lens subluxated for unknown reason, and we had to exchange the lens. There's another patient wherein the lens, multifocal lens, decentered. This is because one of the haptics was fractured during implantation, and the surgeon continued to put the lens. And obviously, we had to do an IOL exchange in this patient, as you can see in this particular video. How to handle unhappy patients. Listening is a very important thing to do to get to the bottom of the reason of dissatisfaction. A passionate hearing of the patient's problems is very, very important. It is important to reassure the patient, and this reassurance gives the positive energy to the patient. Patient will become alright. We have to find out what is causing the problem and ultimately arrive at a solution. Take-home messages are very important. Unhappy patient, look for residual refractive error, PCO, or a mild wrinkle on the PC. CME, always do a OCT preoperatively as well as postoperatively. Dry eye, MGD, ocular surface problem, decreased contrast, glistenings, higher order aberrations of the cornea, especially post-LASIK keratoconus patients, lens tilt, decentration, functional overlay. Ultimately, you have happy patients, happy outcomes, happy surgeons.